everybody. Welcome. My name is Eric Chaconis, and this is the Frontline Primary Care Physical Therapy interview show where we talk with individuals who are practicing in a frontline healthcare provider role as a physical therapist in a primary care setting. Today we have Dr. Ashish Kakar, and he is a physical therapist who's a civilian practicing in the military healthcare system. And so, kind of neat to hear the perspective of somebody who is not an enlisted member of the military, is a civilian, but has all the rights and privileges of a physical therapist practicing in the military. So we're all familiar with that model and how that model allows physical therapists to order imaging, to order medications, and to see patients in a frontline triage sort of provider role. And we get into all sorts of other topics related to diagnostic ultrasound, the federal PT section, and what they are doing in the primary care SIG to elevate and promote the practice of primary care physical therapy. So very excited. Stay tuned for this one. Welcome, everybody. My name is Eric Chaconis, and with me today is Dr. Ashish Kakar, physical therapist in Bethesda, Maryland, working for the military. So, Dr. Ashish, kind of give us a little bit about your background and kind of your current role, and we're going to talk a lot about kind of your role in the primary care system there.
Yeah. Hey, so good morning. Good talking to you, Dr. Chaconis. I'm glad to have you on here with me. Before we get going, I got to just throw out a quick disclaimer. Since I do work in a military facility, I just want to put out that the views expressed in this podcast are those of the author, which is me, and not necessarily reflect the official policy of the Department of Defense or the U.S. government, okay? So I have been working at a military hospital in Bethesda, Maryland now for about 4 years, and it's been eye-opening. I used to work prior at a civilian facility in outpatient physical therapy, and there really is quite a difference. There's, I guess some people call it like advanced practice or expanded scope of practice, right? And it really allows you to do a lot for your patients.
That's awesome. And so most people I think are familiar with the military model of physical therapy, where we have physical therapists working in kind of this frontline provider type of role, doing a lot of triage work with imaging and medications and referrals. And we think of that. And there are enlisted physical therapists who do that, obviously overseas as well as on different military bases. And then there are also a civilian contractor, basically a civilian employee. But that's the role that you're in. So talk a little bit about that and the difference, because some of like your colleagues might work for the VA or military hospital, but talk a little bit about the difference between that versus like an enlisted physical therapist.
Yeah. So you make a great point. For the individuals that are officers that end up becoming physical therapists in any of the military settings, usually they'll have to go through, they get their degree, they go through their officer training school, and then get sent to their first duty station. Those guys end up practicing at multiple type of locations, whether they're out in the theater or whether they're in like at a military hospital like this, or they call it like the med center, right? So medical center. Those guys can kind of be stationed anywhere. We also have physical therapists that are civilian, which is what I am. So I'm a civilian contractor there. We work off certain contracts to fill the needs of the hospital right there. So I'm a physical therapist as a civilian contractor. And we also have like government like physical therapists that work in, so like GS positions that work within the military hospitals along with the VA. And I think it's a synchrony of like being able to bring everybody's experiences together that kind of makes everything work really well.
Right, 'cause the men and women that are trained by the military or officers, and do they have a different scope of practice compared to, say, a civilian contractor or civilian employee like yourself?
They do not, no. So it's all a matter of kind of how much you feel comfortable taking in, right? We have certain physical therapists on the civilian side that'll do certain that may or may not order imaging, right? So you talked about imaging earlier. That is one of the things that we are able to do in the military health system, but there's some people that don't necessarily feel comfortable with it, or they don't necessarily feel comfortable ordering the medication. And that's the case, they don't. But if you're a civilian, right, and you are up to date with everything, you know when to order things, when not to order things, and you feel comfortable with it, you can definitely order any imaging as you need to. And it's the same thing on the officer side. So they're able to order any imaging or anything like that they may need to take care of their patients, really.
So what's that transition like? I mean, you went from kind of traditional outpatient physical, just like most 99% of us are all familiar with, into
Hmm.
this model of care. What was that transition like? What extra training did how did you kind of just learn on the job as far as like the imaging and all that other stuff as far as referrals?
Yeah, I was lucky. I had so there's other civilian physical therapists that have been through this process that were already established there before. So they were able to kind of show me the ropes a little bit. I had to do a lot of research and kind of learn it on myself too. But the more I saw, the more I kind of was like, this really is what physical therapy should be. So I learned more about imaging itself. I went back to some of my notes from University of St. Augustine, right? We have an imaging course that we took, went back to some of the pharmacology notes, although I had a good background in pharmacology even before going to grad school. So I was able to kind of review some things and kind of keep myself sharp. And I think all those things at the end of the day, right? And I'm gonna probably reiterate this over and over again. This is what I personally believe the field of physical therapy in the outpatient setting should be. This is what we should be able to do. And with the current state of the healthcare system right now, with so many shortages of like primary care physicians, right? We can really step in and make a big impact.
So it's really a neat example of how somebody, I'll say, typical physical therapist, kind of jumps into this model and is fairly well prepared. I mean, a little bit of self study, but for the most part, you were fairly well prepared and had success in this model. What are some common scenarios where you order a medication or imaging? What are the most common meds that you order? What does that look like? And then, as far as imaging, what cases do you typically send to refer and order images most frequently?
Yeah. So I think when it comes to the medications, usually there's a list of medications that we are approved, right? So we're not sitting here prescribing Percocet and any of the controlled substances, but most likely it's just going to be like a Motrin 800, right? And even that you have to be careful of, just because anybody they go see will most likely go, "Hey, musculoskeletal condition, Motrin 800." So even that I don't do a whole lot of, right? It's an individual who I think it may be appropriate for at that point in time. When it comes to imaging, imaging is really as warranted. So let's say I have a person coming in. I had an individual I was just recently seeing. He came in for low back pain, some ridiculous symptoms down the leg. We gave him some treatment visits. He came back a month later to see me for his follow up, and he was reporting some symptoms into his neck and then also some stuff going down. I looked at his radiology notes, didn't see any imaging, anything like that there. All his special tests were negative, but still kind of concerning. So I ordered some imaging, lumbar and cervical MRI for him, and we were able to kind of get that done without him having to necessarily go to the ED for something like that, right? And flood that system, especially with the pandemic going on right now. And then even with him having to necessarily wait a couple weeks to go see his primary care physician or whatever it may be to get that set up. So it's kind of point of care, right? You're taking care of the patient as you see fit and as appropriate from the current research and literature.
So a lot of like Ottawa ankle rules and
Hmm.
Canadian ceasefire when you get the trauma cases and stuff like that. It sounds like what you would expect it to be as far as referring for imaging goes. You look at some literature. A lot of times it says the physical therapist frequency in which they will order imaging is much lower. Do you feel like so? You're super selective, obviously, right? You don't feel the need to order images for every single person walking through the door. I'm sure. What's your frequency level? Would you say out of 100 patients, how many do you order an imaging study for?
It's really limited. I would say probably maybe out of 100 patients, maybe like five or six. It's not a whole lot. That being said, though, sometimes, right, they already have images in the system. So even if the image is warranted, it's already in there for you. You don't have to necessarily get it done. Or if it's not warranted and it's already there, then it's there. Beautiful, whatever. But um, not a whole lot. It's fairly selective. I had to say maybe 5 to 10%. It's fairly limited. I think if you're able to do just that great physical evaluation, right, which is something that we do in our profession better than any other profession, because we are able to spend the time with them. It's not a matter of whether other professions can or not. It's a matter of, hey, look, sometimes primary care only has 20 minutes to see that patient. How many things are they going to be able to check off? Are they going to be able to do a great physical evaluation? Maybe not, right? If there's other things that they're checking off, like diabetes, cholesterol, everything else. We're doing focusing on musculoskeletal. We have the time to do it. I think if you do a great physical evaluation, you don't necessarily need to order so much imaging because the patient's telling you what's going on, and then you're seeing it from the evaluation.
What about diagnostic ultrasound?
Yeah.
Is that part of your practice at all?
Yeah, so I use a little bit of diagnostic ultrasound in the clinic. That's been mainly self-taught, so I don't use it a whole lot. We have the great thing is this is we have our physiatrist across the hall from us, and they are great at always kind of coming over, letting us come over there and kind of watch them do some of the diagnostic ultrasound, those kinds of things to help pick up pathology. We do have a unit in the clinic that I will use, and I will kind of look at certain pathologies, whether it just be like a patellar tendonitis, and just kind of look at it from left to right, or tendinosis, whatever it may be. But it allows me to at least give me a little more insight. It allows me to take a look at that patient right then and there and confirm what I think may be going on. But at the same time, I'm not using it to completely confirm that diagnosis. It's still just a piece of everything else that you're picking up from the patient.
Yeah, I love that. Yeah, I'm a big fan. I did a little bit of training in diagnostic ultrasound and took a course with a big group that teaches a lot of it. That's kind of their thing is teaching ultrasound to healthcare providers, and I just felt like man, the applications are just limitless. It's crazy how many different pathologies you can look for that I didn't really think would be appropriate or able to pick it up
Hmm.
diagnostic ultrasound. What so as do you think you'll use it more and more as you sort of I mean it's one of those things where it's just flight time, right? The more you do it, the more you get good at it and stuff. Are
Yeah.
there any other PTs in your department that you work with that are using it a lot?
Currently, I'm probably the one that's using it the most. So with that kind of comes the learning process of just being online, looking at like different websites and kind of getting different references and things of what normal pathology versus abnormal pathology looks like, and then even I'm looking to take on some courses and things, official courses for ultrasound imaging. Just because, like I said, if someone comes in with an acute injury, you can pretty clearly tell there's something going on. And if you're able to just pull out the ultrasound, I think the other thing it sometimes does is it gets that buy-in from the patient, right? It gets that buy-in is, oh man, look at this picture. Like, hey, this is what's going on. Let me listen to my physical therapist. This is what he does. He's gonna get me better. Along with that, just everything else that kind of comes with it in terms of you being able to build that confidence into the patient, just letting you know, hey, look, this is what I saw from my physical exam. And now, yeah, this is what we're seeing from the imaging. Everything kind of lines up.
I want to plug John Jacobson is a radiologist at University of Michigan. He is the gentleman that taught the course that I took. And anyway, that I just think if people are looking for really good resource, his website is an awesome resource, and you can even see some of his lectures. And he has a book out, but it's Jacobson mskus.com, jacobsonmskus.com. And what an awesome website and just a wealth of knowledge for learning in that area. It's really exciting. What are we doing? Are you aware of anything we're doing at a big professional level? I mean, I know you're very involved with the federal PT section. What is that group looking at anything regarding imaging or diagnostic ultrasound and more? I mean, I guess the issue there is just it's not widely adopted yet, right? By us as physical therapists. Across some, you get little pockets of people doing it, but not widely adopted yet. Is that a part of any discussion? Do you know?
So we recently actually, as part of the primary care sig, so I sit on the research chair there. We recently actually put out a webinar by Dr. Keel, who actually is also part of the board there. And he used to work, I believe, at GW, and he was able to initiate imaging. for physical therapists in that hospital system, right? So he recently put out a webinar, and we have it on our website. If you just Google primary care SIG, APTA, and it'll pop right up, and we'll have different webinars. But this one's on there. You can kind of look at how he systematically went about trying to get those things initiated over there. And so that's one of the things we're doing. Obviously, there's a whole separate imaging SIG, and they're very big on these kinds of things also, and they're starting to push a lot, or they have been pushing that kind of information a lot in terms of how appropriate it is for physical therapists to be able to order imaging for their patients, and then how accurately they're actually able to do it versus other healthcare providers.
Yeah, that's interesting. That'll be interesting stuff to look at. So the federal PT section, talk a little bit about that and your experiences so far and your involvement. I know that you're on the primary care SIG and serve as the research chair there. What's been your experience so far? That group, and give us a little bit of a kind of 30,000-foot view of what the federal PT section is and who it serves. Who are the members of that group primarily?
Yeah. So members actually vary. We have members that don't even work in any kind of federal type of setting. So we have members that are out in the civilian setting that want to learn more and kind of network and do more, right? And try to push for what we're able to do in the federal section out to the civilian practice. I think that's to some degree one of the goals of the primary care SIG itself also is to kind of show, hey, look, these things work that we're doing, and we should be able to push this out into civilian practice to take care of our greater population out there too. It's it's a it's an excellent group to be part of, and I think one of the first things that I actually did, one of the things that was part of the federal section was this federal advocacy forum where we met in DC. I'm going to say this was about 2 to 3 years ago. This last one was canceled due to COVID, and I'm assuming this current one's not going to happen, or it'll happen virtually. But we met in DC about 2 to 3 years ago, and we all got together. We kind of talked about where the current state of physical therapy is, what we are trying to push for in terms of like a legislative agenda to help our patients, right? And then we were able to go, and they were able to set up meetings with our current representatives. You go with them, you speak with them, you let them know, hey, this is what's going on. The field of physical therapy is ever evolving, more so than ever. And there are a lot of things that we can offload our primary care physicians on, let them kind of treat the things that they want to treat. The more non musculoskeletal issues, let them offload the musculoskeletal issues onto us, and let's get at it. These things work. And if they do work, we should be pushing it out, and it'll actually help overall save healthcare savings, right? I think we've all seen some of the studies. Was it the Starbucks study, sir, that they did like the low back pain? I know it's a little bit older, but they just did direct access to physical therapy versus going to primary care, imaging, and then everything else to come back around to physical therapy and the cost savings there. So there's a lot of different studies out there to show that it works, and we just have to kind of start to get the ball rolling. And I think a lot of it sometimes doesn't happen until we get out there and we advocate, right? And it's not even necessarily about advocating. I think a lot of it's just about educating. If people don't know, they don't know. You gotta inform them, and if it makes sense, they will follow it. They will follow through on it.
That's awesome. I didn't know the federal section had such a law. Taking that advocacy lead like that is great because that really is the group that we all cite all the time, right? When we're making this argument, we're constantly saying, "Well, look at the military. They've been doing it like this for years and having a lot of great success. It should apply to the civilian sector as well." So as far as the federal PT section and the primary care SIG, I have heard of like maybe they would have a certification for primary care or offer maybe are there residencies that they're looking at developing? Where are we at as far as like the education of all this?
So I believe currently we are, or so the primary care state, not specifically, but they're members of the federal physical therapy section. They're looking to start a certification in primary care. So just like you have like SCS, OCS, they're looking to do one specifically for primary care to encompass a little bit more overall knowledge about not just musculoskeletal, but all the other things that could be contributing to symptoms, referred pain, that kind of stuff. I think we get a good understanding of it in our base level, entry level physical therapy school. But I think it's always great to kind of learn and expand more, especially if you've been practicing even for a couple of years, because things are always changing.
That's exciting. Yeah, I've kept my eye on that, kind of waiting to see something like that come out, and it makes sense it would come from that group. That would be the group that was be pushing it. What else? Any other? What's new and exciting do you think coming up now out of that group, the federal PT section? What can we all expect if we go and get involved? Right? Where are there opportunities to get involved? And that's not a section I personally have ever been involved in. But what would you recommend people to go and try and get involved in that section?
Yeah, I think one of the best things you can do, right? One of the easiest ways, and if you don't know if you want to get involved or you're still kind of on the fence, one of the easiest things you can do is even just kind of follow some of these different groups on like Twitter, Facebook, whatever it may be, right? So the handle for the primary care SIG is just at primary care FPTS. And if you follow them on there, or if you follow us on there, you'll get to see different research articles that come out, different things that we're doing. So we are going to be presenting a couple different courses during CSM coming up in February now virtually. Um, and we'll be able to kind of talk about different things within the primary care SIG and primary care section, really to push out some more of this information on why this works and how you can maybe do some of this in your own facility, right? If you have the evidence to kind of back it up, it's kind of hard to say, no, Dr. Chaconis, you can't do this, right? If you have the evidence, you have the passion to push forward. It's something that you can do. And I think one of the easiest ways and one of the first steps really is just sign up, follow us on Twitter, follow us on Facebook. And if you see what you're liking, right, just go on there, add yourself as a member of the federal section, and then you can easily just add yourself as a primary care SIG member. There's no extra cost to being a SIG member, but you get to learn a lot more. And I think it's a great opportunity for people to learn and expand on their scope of practice too.
That's great.
Yeah.
And on that note, I think what, for you personally, how are you ever going to go back to a regular traditional practice model, right? Like what's your future look like, you think?
Yeah, I think that would be tough, right? I think to some degree after being able to do what you're doing now, to do it competently, if not competently, even better, right? And take care of your patients the way you know you should be able to. It just this just 100% makes sense. I think it would be tough to go back out in the civilian model and be kind of handcuffed on certain things you can do only because of different political reasons or whatever it may be. And just not being able to do what you can do and what you know you're able to do for your patients to take care of them. I think that would be a little tough. There's no doubt about that. One of the things, right, so that I'm doing right now, I just submitted my poster presentation for CSM on a patient that I saw for the first 6 months post-op ACL, completely over telehealth, right? So completely over telehealth, no hands-on, nothing like that. And I think one of the things is the patient had different comorbidities, different things that made it difficult, that made her susceptible, right, to kind of contracting COVID-19. So she wanted to do as much over telehealth as we could. And here's the beautiful thing, right? There's no one handcuffing me saying that, hey, we got to see what the coding says. We got to see what the billing says before you can take care of your patient. It's not so much that. It's like, okay, well, this is how we do it. There is already coding and stuff in there. It's not a matter of, oh, we got to see if the insurance will pay for it, right? It's a matter of you go take care of your person. And if this is the best opportunity and the best way to take care of them right now, that's how you do it. And we did a full 6 months of post-op ACL care completely over telehealth.
That's really a nice. I mean, and that's a similarity. Last time in this show, I talked to Daniel Janti, and he's employed by the Denver Police Department, so he's an in-house PT, just like you are, right? That's the one similarity between all of you is that being directly employed by the entity in which the individual works, you're basically employed by the employer of the patient. the billing is not really a topic, right? That's not a variable that anybody is worried about, which is really, that might be the key difference. Because so you practice in Maryland. Maryland has unfettered direct access, correct? Has had it
Yeah,
since like the 80s or like the
for
late
a long
70s.
time. Hmm.
So when your older civilian role that you were in prior to this, it wasn't an issue so much of the legal ability to practice, right? It was more maybe these other social variables or payment variables that probably impacted it.
Yeah, I think a little bit of that, right, along with maybe patients not understanding they can come straight to physical therapy, but a lot of these bigger hospitals even kind of still just require a referral, right? And they're going to require it just to kind of cover their butt on the back end, just in case the insurance goes, hey, where's that referral? We're not going to pay for those first 4 visits that you did,
Yeah.
right? And it's tough. I mean, they got bills to pay. There's overhead that they have to take care of also. So, unfortunately, there are some of those kinds of things. But I think in this kind of setting, this is absolutely the way physical therapy should be practiced. There's no limitations in terms of financial gain or anything like that. You do what's right for the patient. I think one of the most interesting things that this was day one of me being there, sir. Um, I saw a post-op bunionectomy patient, right? She was maybe like a month or two out from the actual surgery itself. We did the eval. I was with another one of my civilian colleagues who was just kind of running through everything with me. And we gave her a home exercise program. And she's like, yeah, just have her come back in a month. And I was scratching my head. I was like, don't we do 2 times a week for 4 weeks and then do a follow up in a month, right? This was the model that unfortunately was kind of ingrained in us to some degree, and she came back in a month, right? She did her HEP, progressing, doing well, right? I think what we need to take on um, from the physical therapist side, or to be that next level physical therapist, is hey, just kind of expand our minds a little bit and go, do I need this person to come in more? Or maybe I can do more with less, right? They don't have to necessarily take off work. Now, maybe they don't necessarily have to find a babysitter or drive an hour down to come see you. All those things make a impact on patients' lives. And if you're able to do more with less, I think that's definitely the way to do it. And the thing is it works. You don't necessarily need to have someone in there all the time for you to show them how to do different things. I think as physical therapists, as we take on more of this ownership or responsibility of being their primary care musculoskeletal provider, right? That you can go, I'm going to take care of you, right? You go, whatever your musculoskeletal needs are, I'm going to take care of you. And if it's something that I don't think it is, I'm going to refer you back to your PCM. I'm going to refer you to neurology, ortho, physiatry, whoever it may be that's appropriate for you, right? But I think as physical therapists, we just kind of need to expand our minds and go, okay, maybe I'm excellent. I'm supposed to be the individual doing these evaluations and these follow-ups, right? But maybe I don't need to see that total knee patient twice a week directly myself. I can either hand them off to a PTA, right, and have them do those treatments, and I can do more of the evaluation, reevaluation portion of it. But that's my individual opinion, right? That's just kind of how I feel after being in this kind of setting for this long now.
Well, you've seen the efficiency, and so right, it's
Hmm.
that much more of an efficient model of care. In the same way, orthopedic surgeon or a cardiologist would never sit there and try to see every single patient by themselves, like one on one, right? Like you're bringing in and creating a team around you of other providers to deliver the care instead of doing it by yourself.
That's it. And I think there's so many musculoskeletal cases. We all know it's one of the most widely reason for injury or anything like that for anybody to go see their PCM, only second to like the common cold. Um, so the patients are there. I think if we don't necessarily go, hey, Dr. Chaconis, yeah, you got back pain. Now you got to come see me 8 times this next month. You're going to be like, how the hell am I supposed to take off work to come see you 8 times over this next month, right? It's going to make things even more difficult. So I think you adapt your plan of care to what the patient needs.
And the telehealth solution is huge as well. I mean, I'm really excited now to see. So, is this case you submitted for this year's CSM for
Yeah.
CSM coming up here next month? That's cool. So, what's the title so we can all look out for it?
This one, I believe, is just telehealth physical therapy for the postoperative anterior cruciate ligament patient. Um, we recently just had everything approved and submitted just last week, so it should be coming up as a CSM poster once everything kicks off in February.
That's cool. We'll be
Yeah,
on the
I'm
lookout for
excited
that.
for it.
Yeah, that's a really neat. I mean, I just took a telehealth course. I just took Rob Binding's telehealth course, and
Hmm.
so many great scenarios where telehealth is going to be exceptional. I don't know that I ever thought of it in the terms of the ACL. So it's a really, but you can really, you can see anybody right via telehealth and make it happen. So that's pretty neat example. Awesome. So how can we get a hold of you? Are you on social? You mentioned primary care FPTS on Twitter.
Yeah, on Twitter. Yes, sir. Primary care FPTS on Twitter for the primary care sig. And then I myself am on Twitter myself. It's just at Kakar, AKAKAR _ PT. And I'm on Twitter right there if anybody wants to reach out, have any questions. If they see the poster, they have any questions about that. I believe for CSM, they are going to have like a little question board that they're going to put up underneath the poster. But if you want to reach out personally, feel free. I'm always here to help. I think I was lucky enough to kind of somehow get my foot in the door in this type of setting and learn so much from what I'm doing and kind of what physical therapy really can be and should be. I'm more than happy to help out anybody that I can.
Awesome.
Yeah.
Awesome. Thank you, sir.
Hey, no problem. One thing I'd want to finish off with is it is Martin Luther King Day, so we do have to. I do want to just put out there that he's a great man, and just one of the quotes that I really liked that he put out there was, "The time is always right to do what is right." Right. Just if you know what the right thing is for your patient, passionately pursue it until you can get there for them.
That's so true. In so many elements of our society, that's such a true statement.
Hmm.
Awesome. Thank you so much.
Hey, no problem. Thank you, sir.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.